Our next speaker is Professor Ling is Associate Professor of Applied Biostatistics and heads the Health Analytics and Patient Safety stream at the Centre. She's a biostatistician by training, with research interests and expertise in using robust, novel and realistic study designs. Over to you, Ling.
Oops. Too further. I think that was actually a very good segue for the questions and discussion for my session. I hope my talk will answer some of your questions. So medication errors, including prescribing errors, are detected frequently by the clinicians, and the clinicians can report these errors to the incident reporting systems. And here are 3 examples, the errors being detected by clinicians in paper systems. The first one is by a pharmacist, is a green ink. And the second one crossed out by a doctor, you see that. And the third one was corrected by a nurse. So this actually is a screenshot from the electronic systems. You see that example, the orders being cancelled by a clinician and the doctor. A doctor actually can also see, all the medications ordered and also details related to the medication on their screens. So the first objective for my study is to identify the prescribing errors detection rate by clinicians and also the incident reporting rates by clinicians. So to our best knowledge, this will be the first study conducted in pediatric settings. And the second aim is to examine if these rates have changed after the implementation of the eMM. So this is a controlled before and after study. And all the errors we have, the first one is all the errors identified by our research pharmacists using predefined definitions, as Aaron explained nicely in the last session. And this actually is going to be our denominator. And then during the medication chart review process, our pharmacists also flagged those errors being detected by clinicians if they see any evidence on the chart in paper and eMM. And another lot of errors are actually those errors reported to the incident report systems. So we have the incident reports extracted from the hospital systems and also classified by our research pharmacists using the same definition. And as I said, our pink egg is going to be the denominator. So the outcome we're looking at are the proportions of the errors being detected by clinicians out of all these errors identified, and also errors reported by clinicians out of all the errors being identified. And we're also looking at the difference of those errors with serious potential harms. So the error severity scale 3 and plus, as Aaron again explained very nicely. So we have 2 study hospitals. Hospital A, I think you know by now, Westmead, that has the implemented eMM systems. So the data collected right before the implementation, so that's the paper period, and also immediately after eMM. That's kind of the first 2 parts of the step-batch time period. And also we collected the data for the 1 year post-eMM. So in our control hospital, that's Randwick. So it's all only have the paper in place in this study. So we have data collected in 2016 and 2017 in the matching period of the Westmead Hospital. And the first result is the errors detected by clinicians. Let me briefly explain this diagram, this graph. You're probably going to see a couple more. And the y-axis is the number of errors detected by clinicians per 1,000 errors identified. And the x-axis is the 2 hospitals and across 2 study time period, 2016, 2017. And the red dots are for the paper systems. So we have hospital B is all and in paper systems, and only 1 red dot in our intervention hospital. And the blue circle, it's eMM, immediately eMM period, and green triangle is the 1 year post eMM. So I have 2 panels here for the prescribing error and the errors with the serious potential harm. I'll explain the results one by one. So the prescribing error, actually, the detection rate increased immediately post eMM from about 90 per 1,000 errors identified to 150. So that's basically the detection rate increased by 61 per 1,000 errors identified. In other words, 6% increase in the detection rate. And then with the 1 year post, we say our hospital B, the control hospital, the detection rate dropped a little bit, and then, but we look at hospital A, the intervention hospital increased a lot. So relative to the control hospital, remember this is a controlled before and after study. So relative to the control hospital, we see the detection rate increased by 106 per 1,000 errors identified. So in other words, basically 10.6% increase in the detection rate from the paper to 1 year post eMM. For the errors with serious potential harm, again, you see a big error in the arrow went up, the red arrow went up, so that's big increase from, for the immediately after implementation of eMM. Then the detection rate increased by 106 per 1,000 errors identified, 10.6%. And for the 1 year post, relative to the control hospital, the detection rate increased by 105 per 1,000 errors. So that's close to 16%. So lump up all the across different study period and across 2 hospitals, the detection rate, it was calculated the errors identified. We have 9,000 errors identified, more than, and then more than 1,000 was detected by clinicians. So the overall detection rate is 118 per 1,000 errors identified, so that's around 12%. And for the errors with serious potential harm, actually the detection rate is much higher, it's about 22%. I mean, obviously, I think as Joanna hinted before, on the flip side, we probably say that for the prescribing errors, there are still close to 90% were not detected. And for the errors with serious potential harm, that's close to 80% was not detected, sorry. Then who detected errors? So this one, we look at the proportions of errors being detected by different clinical staffs. So I just want to draw your attention on the green bar, that's for the hospital doctors. And so in the eMM system, Hospital A, our intervention hospital, the detection rate by the errors detected by the doctors about 25%. And immediately after implementation of eMM, that went up to 40%. And 1 year post, that went up to 50%. And then looking at the errors with serious potential harm, this rate actually increased much more, for the green bar looking at the doctors, in the paper system was close to 30%, and immediately after eMM was 35%, and 1 year post, that's more than 50% of the errors were actually detected by doctors. The next one, looking at the errors reported to the incidence reporting systems. So that's diagram again, the graph again. So here we're looking at the y-axis is number of errors reported by clinical staff. As you can see from the numbers, it's actually much smaller number, and up to the upper limit of the error bar is to close to 40 per thousand. But this immediately after implementation of eMM, although we see the increase, the reporting rate increased a bit, but the increases are not statistically significant. I'm a statistician, I like to think that way. So you look at the 95% confidence intervals are overlapping for both prescribing error and errors with serious potential harm. And 1 year post eMM, you see the hospital B increased a little bit, and then our intervention hospital went down a little bit, but again, these changes are not statistically significant. They're very small changes, the number, as you can see. Lumped together, you see the number, the last number, how many of these errors been reported to the incident reporting systems. So that's 3 per 1,000 errors being identified, being reported to incident reporting systems. And even for the errors with serious potential harm, that's 13 errors. And we've seen all these numbers from our pediatric hospitals. How do these rates compare with the adult hospitals? So in 2015, Joanna led a study. We published a study on the adult hospitals. And as you can see, the second line is for the adult hospital. Apart from the detection rate of the prescribing errors, that's 192 per 1,000 in the adult hospital, and compared to 118 in the pediatric hospital. And the other 3 rate, the reporting error being reported to incident reporting systems is 3, remarkably similar. And then looking at errors with a serious potential harm, they're very, very similar. And 22% detection rate and the 13 per 1,000 errors being reported. I didn't make up that number, by the way. You can see the confidence interval is actually quite different. Obviously, we have a much bigger number in our pediatric hospitals study. So in summary, after implementation of eMM, more prescribing errors were detected by clinicians, especially by doctors, and the detection of the prescribing error with serious potential harm increased significantly by 10 to 15%, and the reporting rate didn't change. I think, as Jeffrey said in the opening session, we probably should think both System 1 and System 2 approach. So I'd like to point out, 80 to 90% of the prescribing errors identified had no evidence of being detected. So that's something. And the other one is, obviously the reporting, the 3 per 1,000 errors identified, has an incident report. On that note, thank you, and any questions?
Thank you. Couple of questions. Quick question on that. I mean, a large increase in detection with the eMM, was that prompted by clinical decision support tools, or was that just the fact that they actually had access to those records more often, they could find those errors?
I would say probably a combination of different things. As you can see, in the electronic systems, all the drugs listed nicely, so that's probably some combination of the things. Yeah.
Cool.
Yeah.
Rhys Thomas from John Hunter in Newcastle. I guess given that identifying an error is a prerequisite to reporting it, do you have the data of the incident reports in proportion to the identified errors? Because I guess that's going to be an important distinction, because as opposed to the chart review identification, and yet whether there was any difference between the hospitals and pre and post implementation in that sense.
Yes, I do have the data, but I think I haven't really linked them properly, aligned properly yet, but I actually, from memory, I think it's mostly link, so those reported mostly been detected. Yeah.
Lisa?
Hi, thanks Ling. I'm Melba Sarahi from Sydney Uni. My question relates to harm and how these results link to the harm you identified in the harm panels. Were patients who experienced harm more likely to have an error reported?
So you mean with actual harm, so the potential harm reported here, with actual harm, we also did the link, but I didn't report here. So the reported by Virginia, that's 22 harms in the prescribing error the harm cases. We only have 1 being reported in the incident reporting systems.
Sure. Any other questions? Right.
Thank you for that presentation. Rashida Bliss from the Australian Commission on Safety and Quality in Healthcare. I just had a question, which is something I was just discussing with one of my colleagues in the break. I know you compared the prescribing errors between adults and paediatrics, and it was really interesting to see that there wasn't much difference. Did you compare the error types between the two? For example, wrong drug, wrong dose, wrong frequency?
Quick answer, not yet, but I think that's will be the next step. I did look at, I think, adult study we done some time ago. I need to go back to look at it. But with the pediatric, I think the main type are the dose, frequency, and route. Yeah, that's right. Yeah, so the actually detection rate for the duplicate therapy increased a lot after eMM. But that's a very good question. Thank you.
Great. Thank you.
Yeah, thanks. Fergus Davidson from Concord Hospital. So we were the first hospital to implement eMM, and I've studied it carefully over a long time. We've got a massive problem with data because, as you've demonstrated, a very, very small number of incidents or errors are actually reported, and the ones that we review on committees are the ones that have IMS reports. And it bears virtually no resemblance to what's actually going on in the field. But we change our policies according to those incidents rather than what's actually going on. And I'm passionate about incident reports. I've been head of department for 15 years or more. It takes me 30 or 40 minutes to put in an incident report. Twice, I've put in incident reports about the incident reporting system, but I've never heard back. And I think we've just got to take this a little bit more seriously. You know, the airline industry, you have to report things, and if you report it out a certain period, within a certain period, you're not docked or anything, no matter how, culpable you were. We've got a really big problem with data on medication problems, and I think there's an enormous iceberg of error that's not being addressed. I've examined all of the incidents over the first 3 years of implementation at Concord. There's virtually no change in the trend of incidents, and yet still we're not learning from that. There has been a few, quite a few small build changes, but the fundamental issue about human design and the fact that the product is used in a very complex, busy workplace is not being acknowledged. It's not like we're pharmacists sitting at a pharmacy writing these prescriptions. We're doing it on the fly on ward rounds. And the system's not built for that. And similarly, the nurses who are injecting the drug quickly, are doing it because they've got to go and do the 2-person check, which doesn't do anything. We've got a big problem. But I'm so thrilled to hear all this research. Thank you very much.
Any comments on that?
Yes, I take that as a comment, but that's a very good comment. Thank you. And actually just want to add on a bit, I think incident reporting system has been used as like patient safety system, for all the hospitals to check, the errors and all these things. But from the other, I think we know the difficulty of the doctors reporting and how low number was reported. For me, from data person point of view, I think the electronic health record systems potentially give us maybe better opportunity to identify all these errors and maybe, in combination, I don't know, that's probably future. Yeah.
So just an interesting thing, because I used to work for a semiconductor company and they actually had a separate quality control person overlooking those tasks versus we're expecting the workforce on the floor to capture that, and that's part of the challenge. So,
thanks, George. Fantastic questions, challenges. As I said, I arrived in January 19, lovely warm day, and coming from the UK for -4. At that stage, even at that point, I'm trying to work out whether this is a darker cloud to add to the conversation or a silver lining, was that we didn't even have at a state level a unified safety oversight. We had, particularly in this case, an EMR safety oversight, because that was the particular focus. But there are many aspects of digital care that sits outside of the EMR. So we set one of those state bodies up, and I happily co-chair this with Jim Mackey. I'm sure many of you know him from the CEC. One of the outcomes of that, just to loop back to that last point, is the new creation of a state risk register. And some of those items that we're just discussing here, for the first time, were called out. There are 17 current state risks that have yet to be fully mitigated or remediated against. I think the challenge for us all, especially with my title on that one, is that the low rate of pickup. And I absolutely agree. I hope, fingers crossed, that the 17, unfortunately, would probably still be the 17, but we don't have that evidence. The biggest worry there is absolutely the iceberg below, the 97%, may be different. We may be looking at the wrong incidents that are as yet unidentified, either in quantums, that's number one, or even new state risks that we're not yet aware of. So I'll certainly take that challenge up. Let's make it simpler. I think the running theme for the whole day will be of that style. How do we enable people to be able to interact with the system as swiftly and readily as possible? It shouldn't be the impediment, but at the same time, I think what we're also seeing, and again, it'd be lovely to hear your thoughts as well, from people don't go out their way not to report. But as you said, there's many multifactorial reasons behind that. Yet at the same time, the quantum of what's being missed is not just it's a little difficult to use the IMS plus, or it's a little difficult not to have a green button I can just press. There's a lot more going on here for that number, that scale and size. So look, from my side, from Jim, myself, Australian Commission's involved through Amanda Walker as well. This has all happened even in the 3 years. As I indicated earlier on, there's a next generation opportunity, and for all of the audience members here and online as well, there is a huge opportunity to step up into that gap, the 97% gap. Because you're absolutely right, the safety profile of that is as yet unknown.
So I think we've identified a number of discussion topics over lunch, which is now upon us. So please join me in thanking our speakers.